All right, nursing students, put down that sixth iced coffee and listen up. The clinical floor is waiting, the NCLEX is looming, and today we're tackling Module 7, the Older Adult Nursing Clinical Survival Guide. We are doing a rapid-fire, absolutely no-nonsense review of this explainer to get you through your exams and actually keep your future patients safe. Let's get right into it. Okay, I want you to anchor this entire review right here. More medications literally equals more complications. If you remember absolutely nothing else today, please sear this golden rule right into your brain. You know, the older adult body is just a completely different landscape. And honestly, the more pills we add to the mix, the more chaotic things get. Let's hit Section 1, Hospital Hazards and Sneaky Symptoms. Because here's the everyday geriatric reality. Older adults, they do not read the medical textbooks. They're going to present with symptoms completely differently than your younger patients. Let's simulate some exam pressure for a second. You're sitting at your computer, the clock is ticking down, and this absolute classic NCLEX trap pops up. An older adult patient is suddenly confused. Do you immediately check for a fever? What's your gut telling you? Well, the answer is a massive, resounding no, because confusion is the symptom of infection here. Older adults have older immune systems, right? So they often just don't mount that typical fever response to things like a UTI or pneumonia. So if your sweet 85-year-old patient suddenly doesn't know what year it is, that thermometer is basically just a fancy paperweight. Altered mental status is your blaring siren that an infection is brewing. And this brings us to a really massive hospital hazard. For a 20-year-old patient, bed rest is like a spa day. It means healing. But the geriatric reality, bed rest equals rapid, massive deconditioning. For an older adult, a hospital bed is essentially a muscle-eating monster. Literally, if your patient needs new assistance walking after just a couple of days in the hospital, that is deconditioning in action. You've got to get them up and moving. Moving right along to Section 2, the perils of polypharmacy. Older adults usually have multiple comorbidities, and honestly, our system's default is to treat all of those by just throwing more pills at them. So, welcome to the medication minefield. We define polypharmacy as taking multiple medications, usually 5 or more. Now, you might be looking at a chart and thinking, great, this is comprehensive treatment. No, absolutely not. Polypharmacy guarantees an exponential increase in complexity. It massively bumps up the risk for falls, for delirium, and adverse reactions. It's not comprehensive healing, guys. It's a juggling act with live grenades. Let's look at some completely insane drug interactions that you'll see treated like lethal weapons on your exam. Ginkgo mixed with warfarin, you're looking at a severe bleeding risk. Grapefruit juice sounds like a totally healthy breakfast choice, but mix it with statins or calcium channel blockers and you get dangerous toxicity. And then there's Benadryl. In younger people, diphenhydramine just makes you sleepy. But in an older adult brain, this anticholinergic causes severe urinary retention, massive confusion, and falls. Benadryl is basically the arch nemesis of the geriatric ward. Because of all these wild risks, write down this next golden rule. Start low and go slow. Older adults have decreased kidney and liver function, which means they metabolize and excrete drugs much, much more slowly. A totally normal adult dose could actually be a toxic overdose for them. So, we start at the absolutely lowest possible dose and increase at a snail's pace. To safely navigate this entire minefield, interprofessional teams use several really cool deep prescribing tools. You've got the Beers criteria. Think of that as your hit list of potentially inappropriate medications to always avoid. Then you have the stop criteria for meds that need to be discontinued right away, the start criteria to catch beneficial things we might have missed, and stop fall to target medications that practically guarantee your patient takes a tumble. So, how do we actually protect our patients from all of these errors? Section 3, Med Reconciliation Saves Lives. This right here is your primary defense weapon as a nurse. Medication reconciliation is the mandatory process of comparing medication lists specifically during transitions of care. The whole goal is to identify omissions, duplications, and just downright errors. And listen, this isn't just a fun suggestion. It's been a mandatory hospital safety priority since 2006. It literally stops adverse reactions dead in their tracks. Let's break that chunky textbook definition into a simple 3-step survival checklist. Step 1, assess. You need to ask about over-the-counter meds, herbals, and honestly, if they can even afford their pills. Step 2, reconcile. Actually sit down, compare the lists, and catch those discrepancies. Step 3, teach back. Please do not just hand them a pamphlet and walk away. Have the patient repeat the instructions back to you to prove they actually understand the whole shebang. Speaking of transitions, that brings us to Section 4, Safe Transitions of Care. Okay, so we've stabilized the patient, we've fixed their meds, and now it's time to move them. Welcome to the danger zone. Whether it's moving from hospital to home, hospital to rehab, or rehab to long-term care, these are extremely vulnerable periods. The absolute highest risk for medication errors, missed instructions, and hospital readmissions happens right here. As the nurse, you are literally the bridge, ensuring they do not fall into the gaps. But our communication has to adapt depending on exactly who we're talking to. When you're handing off a patient to another provider or the interprofessional team, you use SBAR, situation, background, assessment, recommendation. It's clinical, it's concise. But when you're preparing the patient or their family for a transition, you use the teach-back method in plain, everyday language. Two completely different tools for two different jobs, and both are absolutely vital for safety. Finally, let's talk about what happens when the patient is actually out the door. Section 5, Community and Home Resources. Look, our goal isn't just to discharge them. The goal is to keep them from coming back. Now, this next concept is a classic exam trick, so pay attention. You absolutely must know the difference between skilled and non-medical home care. Skilled home care is covered by Medicare. It requires a provider's order, and it involves actual clinical skills like PT, OT, or nursing for a homebound patient. Non-medical home care, that's for housekeeping, meal prep, and 24-hour companionship. There's no provider order required, and it's usually paid for completely out of pocket. Think of it like paying for premium cable. You really need to know who pays for what on the exam. To help navigate all of this stuff, you do have lifelines. Case managers are going to be your best friends. They coordinate all those complex services. Then there's the PACE program, which provides all-inclusive comprehensive community care to keep older adults safely at home. And don't forget the Older Americans Act, which provides crucial funding for things like transportation and respite care. You are an advocate. You got to know these resources actually exist. Okay, before we wrap up, I am throwing one final NCLEX pop quiz at you just to lock in your retention. Ready? A patient living alone with vision impairment is discharged. What risk needs the most attention at home? Think about the aging body, the medications, and environmental hazards. The answer is falls. It is literally almost always falls. The exact second that patient gets home, those cute little aesthetic throw rugs become absolute death traps. We need to immediately advocate for removing trip hazards, increasing lighting, and getting grab bars installed in that bathroom. So to wrap this explainer up, let me leave you with this. If start low and go slow saves lives, what is one single medication habit that you will change today to protect your future older adult patients? Take these concepts, the polypharmacy, the atypical infections, the med reconciliation, and carry them straight out of your exams and into the real world. You've got the knowledge now. Go catch those errors and keep your patients safe.